All right, and ladies and gentlemen, welcome to part 3 in our trauma playlist. And at last, we have arrived at the quintessential epicenter of trauma, which is bleeding. Bleeding. And most specifically, massive bleeding. So, thinking back to our March algorithm, remember that the very first thing that we identified in our primary trauma assessment, March, was massive bleeding. And so there's a couple other instances going through March when we could be tipped off that there is some kind of a bleed going on other than what's obvious externally, which is more what we would pick up in M, right? Like an arterial hemorrhage that was external. When we get further down the algorithm, we might also be identifying internal bleeds or signs of shock. And so if you'll remember our general trauma matrix that we go over in the first video in this playlist, anytime going down March that we identify that they're having massive amounts of blood loss, either externally or internally, we're going to then simultaneously flip over and go through this algorithm, which we're about to talk about, to control bleeding. And guess what? It's the easiest algorithm in the world. It's literally the acronym B.L.E.E.D. B.L.E.E.D. Literally just bleed. Now remember, our primary assessment is March. We still want to make sure that we're going through that. But this is where teamwork comes in. We can be delegating our, especially BLS providers, to be going through the rest of March, since that's primarily a BLS algorithm. And bleed actually begins with ALS intervention. So we can, on the ALS side, be going through bleed and simultaneously having our BLS partner or provider or other people at scene finishing the March algorithm. And we could effectively go through both at the same time.
One other quick note to point out is that even though we are moving over to the bleed algorithm when triggered to by signs of massive hemorrhage in our March algorithm, we still don't want to overlook airway, especially if it's something that needs ALS interventions, and we're primarily with that talking about needle decompression. You'll still want to make sure to lock that down before getting too involved over here, unless again multiple ALS personnel at scene can allow for some co-delegation. But again, something to think about. Don't get lost in the weeds over here if you have someone suffocating. All right.
So, BLEED, B-L-E-E-D, what does it stand for? Well, the B, I apologize. I know that I've said before, I don't like it when acronyms have multiple words for the same letter. I apologize. B is not that way in this acronym. However, it's easy to remember. B stands for bilateral IV-IO access, okay? So this is really just thinking about our general trauma criteria protocol, and it's this way pretty much in any LIMSA. If they've lost this much blood to merit us using this algorithm, we can pretty much deduce that they're probably a trauma alert just by definition, and they need bilateral IV-IO access. The final two B's that this stands for, remember, bilateral IV or IO, and then the next two B's, it's easy. It's blood or bolus. In our case, we don't give blood, right? So we're thinking more, okay, bolus up to their necessary systolic blood pressure. If they're in shock, obviously we're going to preface lactate ringers over saline. We'll talk about that in another video. But really the blood is actually still good for us to keep in mind, because even though we don't give blood directly, remember that we can transport to a closest critical access hospital that might be closer to us than, say, the Big House, Mercy, or Level 2 Trauma Center. And we can also consider rendezvousing with a medevac, which, by the way, all the medevacs, not air rescue, but all the air ambulances in our area are now capable of giving blood. Reach and PHI now both give blood here as well. So, blood, even though we're not giving it, we can think about, hey, does this patient need blood replacement? Is it that serious of a bleed? And if that's the case, then we need to be targeting our care and destination transport decision in order to get that for the patient as soon as possible, okay? So, bilateral IV-IO, blood, bolus, okay? That's the ALS part. Now moving on to L. L stands for lower the core, raise the legs. And actually, it goes a little bit beyond that. Really, what we're getting at here is shock position, first of all, right? We want to lower the core, we want to raise the legs, because we're trying to, in the case that they've lost a lot of blood and they're in shock, we want to help the body preface using gravity to move as much blood into the vital organs as possible. But the other element to that is that there's actually a few other things that we can consider raising as well. So while we're thinking about lowering the core, that's what L stands for, lower the core, we can also go, hey, I'm lowering this, what do I need to raise? And one of the things that we consider raising is if they have an extremity bleed. If we're lowering the core and they had a massive extremity bleed, we might even consider raising that extremity that we tourniqueted. And the other big one is a head bleed. If they have a head bleed and there's no worry about spinal precautions, like let's say an isolated head injury where we suspect a closed head injury with closed bleeding inside the head, we want to consider raising that head up so that we, again, utilize gravity to help pull blood out of the head and assist with that buildup of pressure in the head, not hopefully getting as bad as it might otherwise. Ultimately, we're not going to be able to stop it completely, but we can definitely help it with patient positioning. So L is really focused on patient positioning, just thinking about, hey, what do I need to lower and what do I need to raise in their positioning on the gurney to help the situation with how they're bleeding, okay? The two E's both start with excessive. It's excessive oxygen, and then the second E is excessive warming. Remember with oxygen that anytime we have a trauma alert, we're going to just go ahead and we're going to just basically wash them out with oxygen. And the main reason is just because if they've lost a lot of blood, they've lost their very ability to carry oxygen. And so if they've lost their ability to carry oxygen, we want to do everything we can to overwhelm the the remaining part of blood that's within them with the oxygen that we can give them. Try to give them the best chance that we can at perfusing. It's not going to be as good as if they had all the blood on board, but we're going to give it our best shot. There's another reason too, and that is that oxygen has shown, especially in recent literature, to increase survivability, specifically in head bleeds and head injuries due to physiological mechanisms we can go over another day. We're trying to keep this one short and sweet. So oxygen shows improvement with head injuries. So anytime you have a head injury, you should really be considering the use of high flow oxygen. And definitely anytime we have a trauma criteria, trauma alert criteria, any kind of massive hemorrhage, high flow oxygen is going to be our key. So excessive oxygen, can't go wrong there. We're not worried about giving too much in this instance. And then of course excessive warming is the next thing. Once we've stripped them, assessed them, searched them, all that kind of stuff, we want to then make sure that we keep them as warm as possible. As we know, hypothermia is part of the diamond of death, okay? Warm them up, one of the leading causes of mortality and trauma, particularly in pediatrics, okay? So excessive oxygen, excessive warming, B.L.E.E. We're on to D.
And once again, so sorry, D is two things. It's drugs and determined stability. Drugs being TXA, and then any consideration for pain management or sedation, and then determination of stability, and we'll talk about that in a second. But first, let's review the protocol for TXA. Remember that we have really three primary categories of things we need per our protocol. The first thing is they have to have sustained some kind of blunt or penetrating trauma to induce the massive hemorrhage needing control. B, they're exhibiting signs and symptoms of hemorrhagic shock, and you have a blood pressure that's under 90 systolic with that. And then the final category is they have to fit in the criteria of being less than 15 years old, and the injury has to be less than 3 hours old.
So again, when we put in an IV or IO, this should also be triggering our brain into thinking, okay, medications as well. I'm giving a bolus of fluid if needed. I also need to be thinking about giving medication. Again, see your protocol for contraindications and indications for TXA. If it is indicated, we want to treat early and aggressively with it. The one other thing to note about it is that let's say that we were triggered to go over to the bleed algorithm because we started going through March. We identified they had an open exterior arterial laceration with bleeding on an extremity. We tourniqueted it immediately, and then we proceeded over to the bleed algorithm. Let's say that we did control that one isolated bleed with our tourniquet. Do we need to administer TXA at this point? And the answer is no. If that was the only bleed, for example, and we were able to control it, you don't need to give TXA at that point. It's only if we have not been able to control the bleed by other means, okay? And then, of course, we're going to continue assessing them through March, looking for signs of internal hemorrhage. But I just wanted to make that clear that in the event that they had just one isolated bleed, and we on the extremity, for example, and we were able to control it with a tourniquet on our way over to do the bleed algorithm, assuming that you really did have control of the bleed, you do not need to give TXA at that point if it's being effectively controlled.
And then part 2, the second thing that D stands for, and that is determination of stability.
Now this is at the very end because as we sweep through our bleed algorithm, this is allowing us first to stabilize what we can, and as we're stabilizing, we're getting a feel for how are they responding to the fluid that they're being given? How are they responding to the positioning? How are they responding to the oxygenation? How are they responding to the airway treatment? And now that we've actually kind of gone through March, hopefully by this point, and we've gone through bleed, now we're kind of taking one last look at them again over everything we've done, and we're going, okay, how fast are they crashing? Because maybe we're throwing the whole kitchen sink at them, and they're still, spiraling faster than we can keep up with. Well, then that's going to possibly indicate, all right, well, then we need to go to the closest facility possible for stabilization. I almost couldn't say that. For stabilization, all right? And so, again, this is just triggering our brains to think, okay, I've done the care, but now with trauma especially, we're dealing specifically with a timeline, and we need to figure out how fast is that timeline running out, okay? So that we make the best decision for our patient. Remember, we can always stabilize them at Trinity if we need to, and then we can resume transport where they need to go. Also, of course, considering the need for aircraft, I would just throw this out there. If it is bad enough that you have to use the B.L.E.E.D algorithm, like I said earlier, by definition, you're already in trauma criteria land. You should already be considering a helicopter at this point. If you're not, then yeah, something's wrong, okay? So that's really it. It's pretty easy. B.L.E.E.D. And just don't forget also that as we're working through that algorithm, we also need to make sure that we're locking down March. We can hopefully knock both of these out relatively at the same time with the help of delegation of duty. And one last point as well, and you're probably already thinking about this. Wait a minute, there's some crossover between B.L.E.E.D and March. There's some similar things that are addressed in both. Yes, and it's supposed to be that way. Like I said, all of our easy acronym systems have a lot of redundancy built into them so that, again, at 2 in the morning, as you're working through B.L.E.E.D and your partner's working through March, one of you is going to remember to warm the patient, okay, as an example. Okay, there's just redundancy in there so that hopefully we don't miss anything, or at least we minimize our mistakes under duress, okay? B.L.E.E.D. Practice it, get familiar with it. I hope it helps.